Now, we are joined today by our Executive Vice President, Brenda Lillay, and Crystal Scott, Visualution's lead coding supervisor, who will introduce our agenda and walk us through the presentation. So with that, I'll turn it over to them.
Good afternoon. This is Brenda Lillay. As Daryl said, I'm Executive Vice President for Visualutions, the revenue cycle management services of our organization are under my purview, and we are pleased to give you some insight and information on the new evaluation and management documentation changes that are coming up for 2021. This is the first significant change to evaluation and management calculations for a good number of years. So we wanted to give you some insight as providers and managers and coders. And I want to introduce Crystal Scott. She is our lead coding supervisor, and she will drill down into the agenda and to the information to help you and your organization make this transition. Crystal?
Good afternoon. As Brenda stated, our presentation today will be to introduce and go over those new 2021 E&M evaluation and management codes. She stated correctly that I am a lead coding supervisor. I have 2 certifications, CPC and COC, and I've worked in medical records, billing, and coding for 28 years. So I have only seen one change for the coding documentation guidelines, and that was back in 1997. So I'm really excited to help you get acclimated to these highly anticipated, much needed changes to our documentation requirements for office and other provider evaluation and management services. So today I will discuss a brief overview of the changes, a discussion of the new requirements of history and exam documentation, a new patient leveling change, guidelines for using medical decision-making for E&M leveling, as well as the new guidelines for using time to determine E&M level. We'll also briefly cover the use of the new prolonged care code, and we will revisit the ever-present role of medical necessity in care and documentation of evaluation and management services. To repeat, please feel free to enter any questions into the GoToMeeting questions section, and we'll have the opportunity to answer those questions at the conclusion of the presentation. So let's just jump right in. Between July of 2018 and July 2019, the AMA and CMS convened health professionals to simplify and streamline the coding and documentation for E&M office visits, making them more clinically relevant and reducing the excessive administrative burden. Reducing documentation overload and providing physicians more time with patients, not paperwork, was the fundamental purpose of overhauling the E&M office visit guidelines, according to AMA President Dr. Susan Bailey. So the January 1st revisions are being made to the CPT codes related to office and other outpatient services, collectively known again as E&M. These changes, which were announced by CMS in November 2019, are again designed to address the administrative burden of documentation in clinical practices. So understanding when these changes are coming and their benefits and impacts is essential for all members of the care team and the revenue cycle team. So let's revisit first our historical view of calculating history and physical exam levels. Prior to January 1st of 2021, the descriptors for the levels of service E&M recognized the 7 listed components. Of these listed components, the first 3 of these, history, exam, and medical decision-making, are considered the key components in selecting the level of E&M service. The only exception to that rule is in the case of visits that consist predominantly of counseling or coordination of care. time could only be considered as a deciding factor in the encounter level when that counseling and coordination of care dominated more than 50% of the encounter. And that had to be explicitly documented by the provider. So historically and currently, the extent of the HPI, review of systems, and past family and social histories obtained and documented is dependent upon the clinical judgment and nature of the presenting problems. The nature of the presenting problems and suggested times were provided in some of the level descriptions in CPT to assist the physician in determining the level of service. However, the level of service had to be supported by a specified number of elements documented within the patient history and physical exam. Key elements of the E&M office visit overhaul now will include eliminating history and physical exam as elements for code selection. While significant to both visit time and medical decision making, these elements alone should not determine a visit's code level. The clinician is still required to document the history of present illness, so we will remain in the current methodology for that, but the current methodology of scoring those history and exam levels is no longer required. And this will allow physicians to choose whether their documentation is based on medical decision making or total visit time. This builds on the movement to better recognize the work involved in non-face-to-face services like care coordination. Changing medical decision-making criteria to move away from simply adding up tasks to instead focus on tasks that affect the management of the patient's condition. So my recommendation at the beginning of every documentation for every patient encounter, the provider must choose whether to document and select E&M level based on MDM or based on time. It's not necessary for the provider to choose one or the other for all of their hospital services documentation. However, it will be very difficult to make this decision later after the encounter if the documented elements used to calculate either of those levels is absent from the medical record. Let's walk through our new history and examination documentation. So the new history and exam documentation guidelines are a significant change from the previously regimented, strictly numbered documentation. Office and other outpatient services include a medically appropriate history and physical examination when they are performed. The nature and extent of the history and/or physical exam is determined by the treating physician or clinician who's reporting the service. The care team may collect information and the patient or caregiver may supply information directly, i.e. the patient portal or questionnaire, that is reviewed by the reporting clinician. Again, the extent of the history and physical exam is not an element in the selection of the new office or outpatient services leveling. Now I'll go over briefly there is a slight change in new patient E&M leveling. Historically, and will go forward, a new patient is one who has not received any professional services from a clinician of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. An established patient is one who has received professional services from the physician or other clinician of the exact same specialty and subspecialty for the same group practice. Notably, in many states, the payer guidelines do vary. Some MCOs do not follow the 3-year rule, instead deciding to go with the once seen, always established patient criteria. So although the definitions of new versus established patients have not changed, one of the other significant changes to the guidelines in 2021 is the elimination of the 99201, which is the code used for new patient straightforward medical decision making. So to report these services going forward after July 1st, excuse me, January 1st, 2021, we are now instructed to use 99202. It's important to note that for office and other services where the physician is supervising the clinical staff, such as nurses or medical assistants that are providing the service, that 99211 that they use is still going to be in effect. They are only removing the 99201. So in the documentation requirements for codes 99202 and through 99215 are changing. The codes are used in the office or in hospital outpatient departments. The change documentation rules go with the codes, not with the location where the services are provided. That means a consultant using a new patient visit code for a patient in observation status will select the level of service based on the new CPT documentation rules, not the existing 1995 or 1997 rules. It's important to note that Medicare does not recognize consult codes. So when a provider is seeing a Medicare patient in observation, the consultant would set their E&M level based on the new guidelines. If there are patients in a situation that they are seeing a patient for a consultation and a commercial carrier is present for that patient, they may still recognize the outpatient consult codes, but the outpatient E&M leveling service codes are the ones that will all be accepted by various coders, various insurance carriers along with CMS. So the services that are affected are not only our office visit codes, but also our observation care services and OB triage visits. Question. So what happens if a patient's status changes from OBS to inpatient? The initial hospital visit codes would be used to report the consultant's work, codes 99221 through 99223. The level of service will be determined by the existing 1997 or 1995 E&M guidelines. So the recommendation, what should clinicians do who see patients in observation? They would need to continue to document observation services using the existing guidelines. And then if the patient's status changes from OBS to inpatient, the limitation on the level of service will be the complexity and not the history and exam. And a sample of that is here. One of the key differences with the new CPT guidelines for our office and outpatient services is that neither a history nor exam are determining factors in selecting a level of service. So let's imagine that the physician documents a detailed history and exam, and the medical decision making is moderate. Using the new rules, that visit would be billed as a 99204. However, if the patient's status changes to inpatient, the physician would be limited to the level 1 initial hospital service, 99221, because of the level of history and exam. And if the visit had either an expanded problem focus history or expanded problem focus exam, it would not meet the criteria even for the lowest level of initial hospital care. So now let's delve into the medical decision making. So selecting at the beginning of the documentation of the encounter would be your medical necessity if that is your choice to bill based on this criteria. Medical decision making includes establishing diagnoses, assessing the status of a condition, and/or selecting a management option. medical decision-making in the office or other outpatient services, those codes are defined by 3 elements: the number and complexity of problems that are addressed, the amount or complexity of data to be reviewed and analyzed, the risk of complications, comorbidities, and mortality of the patient management decisions made at the visit that are associated with the patient's problem, the diagnostic procedures or treatments. So medical decision-making mistakes are often in provider documentation. One of the coding and documentation mistakes that providers make most often is listing the problem without a plan. So providers can infer the acuity and severity of a case without redundant documentation. Adequate documentation for every service date helps to convey patient complexity. Although the problem list may not change dramatically from visit to visit, the documentation associated with the service date in question, not the entire medical record, is what is reviewed in case of an audit. So providers should be sure to formulate a complete and accurate description of the patient's condition with a succinct plan of care for each encounter. Listing problems without corresponding plan of care doesn't really corroborate the physician management of that problem, and it might cause a downgrade of the complexity. Listing problems with a brief generalized statement such as DM or CKD, CHF, continue current treatment plan. That diminishes the complexity and effort put forth by the physician. The next element in MDM is the amount and or complexity of data to be reviewed and analyzed. Data is divided into 3 categories for this purpose: tests, documents, orders, or independent historians, independent interpretation of tests, discussion of management, or test interpretation with external physicians or other clinicians or an appropriate source. And the final element of medical decision-making is the risk of complications, morbidity, and or mortality of the patient management decisions. This includes the possible management options that were selected, as well as those which were considered but not selected. For example, a decision about hospitalization that includes consideration of alternative levels of care. Other examples include a psychiatric patient with sufficient degree of support in an outpatient setting, or the decision not to hospitalize a patient with advanced dementia with an acute condition that would generally warrant inpatient care, but for whom the goal is palliative treatment. According to the AMA, definitions of risk are based upon the usual behavior and thought processes of a provider in the same specialty. The consensus is that trained clinicians apply common language usage meanings to such things as high, medium, low, minimal risk, and they don't require quantification for these definitions. For the purposes of medical decision-making, the level of risk is based on the consequences of the problems addressed at the encounter when appropriately treated, including decisions related to the need to initiate or forego further testing, further treatment, or hospitalization. So to give you a more visual idea of what our new MDM level selection chart, it has some elements of our old MDM leveling chart, and you'll see that as we review throughout. But there are some changes, and those changes are more defined and more clear in each level. So based upon this chart, you can see from the far left column that the code 99211 does still exist. It is unchanged. But then you also will see that it skips right over the 99201. As we've discussed, it is being deleted. and the levels of service do now even out for established and new patient. They line up. So straightforward decision making with minimal number of complexity of problems, along with minimal or no data to be addressed, and the minimal risk of morbidity from additional diagnostic testing or treatment. Below are those that correspond with low levels of MDM, low number of and complexity of problems addressed. And I want to be clear to point out that under low, you will see very distinct or statements. So all of these do not have to be met at once. Only one of each needs to be met. So if you have a patient with one stable chronic illness, their number and complexity of problems addressed would be low. And onto the, excuse me, onto the amount and or complexity of data to be reviewed and analyzed. So under low MDM levels, the limited amount or complexity of data must meet the requirements of at least one of these two categories. And listed here are tests and documents, any combination of the two from the following: review of prior external notes from each unique source, review of results of each unique test, ordering each unique test. Or category 2, assessment requiring independent historians. So if you have either of these criteria met, this would meet a limited level of data. Moving over to the risk of complications or morbidity or mortality of the patient management, low risk of morbidity from additional diagnostic testing or treatment. And as you can see, the documentation guideline is based on the provider's decision as to the risk level. And moving on to moderate levels of medical decision making. These also have several or statements. I will not go through them all for you, but this is a representation of the new MDM leveling chart that the AMA has published. And when you do receive the slides for the presentation, there are links to that if you've not already seen those documents that explain their changes. And finally, last but not least, the high level of MDM. And these levels that must be met for 99205 or 99215 still apply from many of them from our prior MDM leveling categories. So for high levels of MDM, you would have one or more chronic illnesses with severe exacerbation, progression, or side effects of treatment, or one acute or chronic illness or injury that poses a threat to life or bodily function. Beyond that is extensive data for categorically the amount of data versus or including the complexity of the data that needs to be reviewed for this to meet the extensive level for a data. And finally, the high risk of morbidity from additional testing as well as from the treatment. So high risk treatments, et cetera, as well as drug therapy requiring intensive monitoring for toxicity. Those you may find very similar to the verbiage used currently for high risk of morbidity or mortality. Next, we will go through in detail our new option for selecting E&M leveling based upon time. The option to use time for billing 99202 through 99215, you must keep in mind the same day rule. So count only practitioner's time on the calendar day the patient was seen. You cannot include time on any other day, and it does not include staff time. Do not include post-visit time, such as the evaluation of labs or other tests or discussions with the patient or other providers that are taking place on a subsequent day. Timed billing for these E&M services requires a face-to-face service by the physician, advanced practice nurse, advanced practice registered nurse, or physician assistant. The new CPT rules allow all of the services listed here to be included in the total time. So in that total time, that will be the deciding factor to what level of MDM you'll select. Clinician time includes the following activities whenever they are performed: preparing to see the patient, i.e. review of the tests, obtaining or reviewing separately obtained history, performing a medically appropriate exam and/or evaluation, counseling and education for the patient, for the family, or for another caregiver for the patient. Continuing, other services included in the total time are ordering medications, tests, or procedures, referring and communicating with other healthcare professionals when not separately reported, documenting clinical information in the electronic or other health record, independently interpreting results not separately reported, and communicating results with the patient, the family, or other caregiver. Also, care coordination that is not separately reported. So all those items listed when in parentheses not separately reported means that you've not coded and billed for those services in another CPT. So here is our new go-to rule for the time ranges associated with each E&M level. And I'll give you a moment to review. The 99202 time range for new patient, straightforward or low or minimal decision making from 15 to 29 minutes. And for an established patient, 10 to 19 minutes. So these are our new time guidelines and what codes they are associated with. A few tips in documenting time. Clinicians can describe what was done and document the time in a single statement. Quote, I spent 30 minutes reviewing the patient's diagnostic tests, seeing the patient, talking with the visiting nurse, and documenting the record. It's not necessary to note how much time was spent with each activity. Counseling and coordination of care will no longer need to dominate the service for you to apply time-based coding. Use the practitioner's time only, the billing practitioner, not clinical or other non-clinical staff time. And the nature of the work must require the practitioner knowledge and expertise. Waiting on hold for pre-cert authorization would not apply, but a peer-to-peer discussion with a physician at an insurance company would apply. So for code selection to be made based on time, again, the documentation of the start and stop times, as well as the completion of the medical record documentation, becomes imperative under the new guidelines, the same day rule. For this reason, I cannot stress enough the importance of removing old habits of completing the chart for patients days after the services are rendered. Even when code selection is based on medical decision making, documentation for all the data elements and risk determination highly relies on the provider's memory of events. And those do tend to blur together in those subsequent days. So January 1st, we may need to get our t-shirts out that remind our providers that the same day rule should be followed. You can only count practitioner time on the calendar day the patient was seen. So charting and documentation should be completed the same day, whenever and wherever possible. This is more important now than ever. And with the decrease in documentation burden, the hope is that the completing of the electronic medical record at the time of service will be easier than it has been in previous years. Now we'll briefly visit the prolonged service code that has been released with this change. The documentation guidelines created a new prolonged services code, which is 99417. This is listed for new patients, services lasting 75 minutes or longer. See prolonged services 99417. And for established patients, it would be 55 minutes or longer to use the 99417. I'll stop to make an important note that for FQHCs, prolonged services codes are not listed as qualifying encounters. So prolonged services may be billed and payable when the provider is providing care in a non-clinic based environment such as OB triage and or observation places of service. So these extended services must be very well documented. The prolonged service code is used to capture each 15 minutes of critical clinician work beyond the time captured by the office or other outpatient services E&M. So they are to be used only when the outpatient code is selected using time. You cannot assign a prolonged services code with an E&M level that selection was based on medical decision making. For use of the prolonged care code, it also needs to be accompanied only by either the 99205, which is our highest level for new patient care, or a 99215, which is the corresponding level for established patients. So it must exceed the time ranges specified by these two codes. Keep in mind that only a full additional 15 minutes of work must be met for the prolonged care to apply. Prolonged services listed that are less than 15 minutes should not be reporting. So this also allows in those outpatient settings, the outpatient OBS or OB triage, that this can be reported for non-face-to-face or face-to-face care on the date of the encounter. So it eliminates the reporting of a code previously used in this space, 99354 or 99358. So again, please note that prolonged services, as well as the new released code, are not qualifying encounters for in-clinic FQHC work. They would only be used by the clinician in an outpatient service at the hospital. And this gives you an example of how to report that prolonged visit code with a new patient encounter. Anything that is 75 minutes or less would be a single E&M service code. Anything 75 to 89 minutes would be 99205 and 99417, and so on. And this displays the established patient codes using the prolonged visit services as well. Now let's delve into the role of medical necessity. As a final point, medical necessity, not MDM, is the single most important driving force of code level selection. It is the criterion for the level of service that's provided and therefore the code level selection. CMS expects and the rules still require that the code level chosen must accurately reflect the level of medical necessity documented in the chart. Providers are still obligated to select the code level that corresponds to the severity of the presenting problem, intensity of management, and other aspects of medical necessity. Coders are required to utilize the new guidelines for code selection based on the provider documentation. And coder rule number 1, if it was not documented, it did not happen. This concludes my presentation, and we now welcome any questions you may have in the chat.
There are 3 key points that I'd like to bring out just in summary before we get to any questions. Daryl, one is just bringing your attention back to same-day rule. That includes any documentation in your electronic medical record if it's performed on the same day. That's a big win for our providers, but we have to adopt that same-day rule. Another call out would be on our practice management systems, our EMRs, we would want to expire the 99201 CPT code so that that's not utilized after January 1st of 2021. And the other call out might be you could possibly in 2021 see a shift in your bell curve for your evaluation and management codes. Those of us that kind of keep track of that that usage, there will be a shift if your practice models the time element on your evaluation and management codes. So, Daryl, are there any questions that have come up?
I'm not seeing any questions at this point other than we do have one, and that would we be able to share the slides. And yes, the slides will be available to download along with the video to review later today. So they will both be available on our website. If you just go to the webinar menu item on our website, you'll see the day's webinar and you'll be able to download and view those videos. But that's the only one I've seen.
The website address URL is
www.visualutions.com.
Right. Any other questions?
Not seeing any at this point.
Not seeing any. Wonderful. Hold on.
Does the time have to be strictly documented by the provider? Marissa is asking.
Crystal,
Yes,
you want to take
the clinician must document their time. When I'm not sure, Brenda, you can help me with this. A lot of those software, I'm not sure about what will be made available to the provider as they document, but if they choose to use time as their deciding factor, they will need to document themselves when they began reviewing the patient record before the exam took place, the time spent face-to-face with the patient, and any subsequent time that is reported does need to be documented by the provider of those services, by the billing provider.
But it is okay to document as a total amount of time where the provider says I spent 30 minutes.
Yes. Yes.
For this patient, yes. Some of your EMR content forms, many of you utilize perhaps Alliance forms, or you've got internal folks that develop your content. A lot of, we would anticipate that some of those forms would have that start and stop time embedded in them as well.
All right, so we have, I'm sorry, go ahead.
It's okay. One of the things that you may find difficult, and the reason that start and stop time is important is because if it is not documented as far as start and stop times, and the provider does not document at the time of service while the patient is still there, or as soon as the patient is beginning the service, that's going to be based on provider's memory, even at the end of the same day, to go back through their patient roster for that day to remember exactly how much time was spent with each patient. You can only report 1 minute one time. You can't report overlapping time periods.
Okay, let's see. We have Sheila's asking, so the only documentation of the time is a statement as shown in the slides. Do you need to enter a start and end time?
Again, it is not a strict requirement to have the start and stop time. However, the documenting provider would be relying on the memory of the amount of time spent for each patient. So if they enter a patient room, leave the patient room, enter, another patient room, spend time with that patient, the nurse goes in, it can get very convoluted if there are not start and stop times documented in the chart.
Okay. Bethany is asking, can we still use the observation codes 99218-9920 if the documentation supports it for the hospital obs visit? 99220, she said.
So the observation codes are still in effect. However, there are going to be fewer, currently Medicare does not accept them, and many commercial carriers do, but there is that in between, whether if you use the observation care codes, you would need to remember what the insurance carrier is for the patient and whether or not they accept observation care coding. So if you're documenting and seeing a patient as an OBS patient and that patient's service level changes as far as whether they are determined to be inpatient, if that status changes, your documentation will be lacking in some ways to assign codes for the E&M level.
Okay, and I think we're at time, Mr. Darrell.
Oh, I do have one quick question. As Janine is asking, can you repeat the prolonged rule for FQHCs?
For FQHCs, the prolonged services codes do not apply in clinic. You are still going to be getting your flat encounter rate for each of your Medicaid, Medicare encounters. So prolonged services codes for patients with Medicare or Medicaid will not be codable, billable for in-clinic services. The providers would bill that prolonged services code if the time period extended past 75 minutes for a new patient and past 55 minutes for an established patient in the OB triage, say, or the OBS location of care.
But you would be able to utilize those codes for your commercial payers. It just would not render you additional monies on your encounter rates for your Medicare and your Medicaid that pay in an encounter rate. Is that correct, Crystal?
Yes, that is correct.
Okay. So a point to take there would also be that you've got two prolonged service codes there. One of them I believe is new for this year. You would want to go ahead and obtain that pricing and get those loaded into your practice management and EMR for your providers to order.
If there aren't any other questions, we want to thank you for attending our session today and hope you found the information presented helpful. Let me remind you that the recording of the session will be available on our website along with the slide deck hopefully by end of today. If you have any additional questions, please send them to info@visualutions.com and we'll do our best to get you an answer as soon as possible. Again, thank you for attending today and have a wonderful rest of your afternoon.